Hello, everyone, and welcome to the HHQI Cardio Land webinar. This particular meeting is held in February of 2015, and I mention that only because this is being recorded, and we don't want you to get confused if you do go back and listen to this again. The content presented today will be available to you on the website as in the archived recordings. So we'd like to welcome everybody, and thank you for taking the time to join us today, because the content that is going to be presented by Dr. Karen Hudman is something that we hope that you will be able to implement almost immediately into your current practice. Now, Karen will be along in a little bit and be able to introduce herself and give you more of her history of how all of this has impacted her practice. For those of you that I haven't met, my name is Cindy Sun. I'm one of the RN project coordinators on the call today. And with us, we also have Stacy Deslick, who is a health information data analyst. And Stacy will be along in just a minute, actually, to talk about what's going on with the registry. So before we go on, I want to just mention that this is a webinar, but many of you have called in. The lines are currently muted. We'll unmute the lines a little later in the call for Q&As, but you can also chat your questions to us through the chat window on the right side of your screen. So please use either way. If you are using the computer only, no phone, not phoning in, you'll only be able to communicate through the chat window. So please submit all of your questions that way, and we'll get to as many as we possibly can. So at this time, I'm going to go ahead and turn this over to Stacy for Stacy's Corner and a campaign update. Stacy? Stacy, you may have us on mute.
Cindy, this is Misty Dyke. Stacy might be dialing back in. I don't see her on the panel.
Oh, okay. Well, it's no problem at all. Now, I'm not as good as Stacy, so I'll apologize to all of you in advance, but I can tell you she had some really interesting news to share with everyone today. And one is that the measured performance rates are holding steady. So this is talking about the Home Health Cardiovascular Data Registry, or the HHCDR. So for all of you that are performing on that, we thank you for continuing to do that. And it's really interesting that what we have found is the aspirin, which was the measure that was the most abstracted in the past, this month, blood pressure is catching up and tobacco has surpassed it, which is very interesting considering that's the topic of our conversation today. So for all of you that are continuing to abstract, thank you for doing that, and we hope that you're starting to see some value to what you're doing. We know that abstracting and entering information into the registry is new, but hopefully this is starting to show up as to where you can focus your efforts and where are some gaps in care, or do you have any gaps in the care that your patients are receiving. So it'll be interesting to watch over the coming months to see if tobacco remains the most abstracted or if blood pressure or the hypertension measure takes over. So we'll go ahead and watch that. We'd also like to say congratulations to St. Rita's Home Health from Lima, Ohio. St. Rita's Home Health was the first agency in January to close out their data for the month. So keep in mind, we want to highlight all of your all's efforts. So we look forward to seeing who's going to be first, who's already closed out their data for the February month. So with that, we will go ahead and turn this over to Dr. Karen Hudman and ask that Dr. Hudman, go ahead and introduce yourself, because I want you to understand her intricate knowledge of this entire topic. So with Karen, thank you. I'll turn this over to you.
Great. Thanks. Can everybody hear fine on the other side?
Absolutely. You sound great.
Perfect. Okay. So I am a professor at Purdue College of Pharmacy. My background is in pharmacy. I am a pharmacist, but my doctorate is in public health. And as a graduate student at the University of Texas MD Anderson Cancer Center, I started studying tobacco because, quite honestly, it was personal. My mother had died of tobacco-related illness. She developed lung cancer when she was 49. She was dead at 50. And so as a graduate student, a blossoming student, I was looking for an area that was meaningful to me, but also could have a large impact on public health in general. So as I was pursuing my doctorate in public health, I was studying epidemiology, I was studying behavioral science, but I still had my clinical background from pharmacy, and I was trying to find a way to merge those two fields together. And it made a lot of sense at the time, and it still does today. I just turned 50, the age my mother was when she died. So I've been studying tobacco for quite some time, and I've been studying it in different venues. I've studied the genetics of tobacco use, looking at predictors of individuals starting smoking based on their genetic profiles. I've studied ways to measure tobacco use and addiction. But the most important thing that I've done, at least from my perspective, for my career, is developing a tobacco cessation training program. And when I was at the University of California, actually before that I was at Stanford Research Institute, I started working with a group of faculty, pharmacy faculty across the state of California to develop a tobacco curriculum, because I had just completed a survey of pharmacists throughout the state of California that showed that like less than 9% had formal training for helping patients quit smoking. But they were almost all of them were interested in getting training. They thought it would increase the number of patients they counseled, the quality of their counseling. They thought they could make a difference. And so to fill this gap in knowledge within pharmacy, which is actually not unique to pharmacy, it's really all health professional disciplines have a huge void in the amount of tobacco education training that they receive as clinicians during training or postgraduate. So we developed a program, started with pharmacy, and then we've expanded to every other discipline, essentially, working with different groups throughout the country, which kind of brought me together with this group, which nobody's really looked at much about tobacco for home health care. And so I was very interested in this, and we can talk a little bit more later about why I think that the work that you do could have an enormous impact on tobacco cessation initiatives that have been started in other settings and then transitioned into the home health care. So the program that we developed is called RX for Change. It's been in existence unbelievably 15 years, and I count the gray hairs that I have from all of that. But we developed it without funding. We then later got a grant from the NIH to disseminate it to schools of pharmacy, and we had like 98% of the schools participated in trainings, and 85% actually adopted the curriculum. So we've had a massive change in the pharmacy profession for our preparedness for helping patients quit smoking. So, but that's not where, that's great to be doing in the pharmacy, but it's even more important to work with other disciplines, because what we do know from the clinical practice guideline, which was published in 2008, it was the third version, is that when patients hear the quit smoking message or get assistance from multiple types of healthcare providers, they're much more likely to be able to quit and to stay quit. And so it's an important kind of approach that we take now in helping patients quit is more of a team-based approach. That's what we're promoting. So we know back 1964, and I always remember that because that's the year I was born. This was C. Everett Koop, who I think was probably my favorite Surgeon General, and he said cigarette smoking is the chief single avoidable cause of death in our society and the most important public health issue of our time. Every form of tobacco is harmful. They're harmful in different ways. Some are worse than others, but all of them are harmful, and none of them should be promoted by a healthcare provider ever. And so we recently had the 50-year anniversary of that, and there was a new Surgeon General's report that came out, and I was fortunate enough to see and meet the new Surgeon General give a talk about that report earlier in 2014. So we do know that the trends in tobacco use have gone down substantially. If you look at this graph, males have always been higher than females, but now we're under 20%, and we have been for a couple of years, but the decline is slow. So there's more work to be done. But the good news is that almost 70% of patients who smoke want to quit. So to me, that's an opportunity. Most of them don't know how to do it, how to get the best type of help. Most of them try to do it without help, which is, not a good thing, and I'll show you some data in a minute. And the other good thing is that most have tried to quit in the past year. However, if you see a 53% or so tried to quit in the past year, but that raises the question of why aren't more being successful? We have successful methods. We need to use those, and we need to recommend them to patients. And so that's part of the mission of what we do with RX for Change and our faculty across the country. Tobacco is harmful. I don't need to tell anybody on this call that. Here we list some different gases and particles. It's all bad. Nicotine is actually not the harmful part of tobacco, but it keeps people coming back for more. It's the addictive component that keeps bringing them back, and they're exposed to the other human carcinogens. And so there are 11 proven. However, there's almost 70 that are actually suspected, with a pretty significant amount of evidence to suggest that they really are carcinogenic, but more data need to be shown to show that they're proven. So, as I mentioned, nicotine really doesn't cause the ill effects of tobacco use, contrary to what a lot of people think. So In 2014, this is the report of the Surgeon General that I just mentioned. You know, it's a very thick document. If you haven't seen it, I encourage you to try to get your hands on it and take a look at it, at least feel how heavy it is, because there's so much evidence. You know, tobacco use is probably the most studied topic ever, and you know, within the realm of health care, in terms of the evidence for what it, you know, the negative health effects, but also the, you know, the benefits of quitting are very well documented as well. So here we list a lot of the major conclusions related to this report. And on this next slide, I want to highlight that tobacco causes negative effects on virtually every system in the body, every organ system, everything. And so here we have the long list that comes from that report. And so, you know, we often think lung cancer, and, you know, alone is the #1 tobacco attributable death. It's actually cardiovascular metabolic diseases. Now, if you lump together lung cancer with other cancers, you know, it is higher than cardiovascular disease. So, but either way, no matter how you look at it, no matter how you slice it, cardiovascular and cancer are at the very top, with pulmonary just slightly behind it. And that's what you expect. But we also have a lot of deaths related to secondhand smoke, which can be very important in the home environment, which can be very important to the work that you do as well. So we're converging on 500,000 deaths annually, which is a lot of people that could, their deaths could be prevented through tobacco cessation or failure to initiate tobacco use. So we're back to this slide. I highlight in red two specific areas that I want to talk a little bit more in depth about, because we are on a cardiac discussion group here. Talk a little bit about the cardiovascular diseases associated with tobacco use and kind of what the mechanisms are, but I also want to focus on postoperative complications here at the bottom, because transition home after surgery is also, you know, something that home health care is responsible for. So let's talk a little bit first about cardiovascular disease. And so there are many postulated mechanisms. We know that people who smoke are more likely to die due to tobacco use. We know that people who smoke have worse lipid profiles. You know, they have inflammation, they have strokes, thrombosis. And so the mechanisms that underlie this are caused by tobacco. You know, so for example, thrombosis, smoking activates platelets, and it increases platelet aggregation, which leads to stroke, right? So blood clots. Patients that smoke have lower HDL cholesterol levels, which is the good cholesterol, and higher LDL, VLDL, and triglyceride levels. And so that affects the lipid metabolism. So all of these factors working together put a stronger load, a cardiac load on the patient, makes the heart work harder. And it increases the oxygen demand, and it decreases the oxygen delivery. So all of these factors working together can lead to cardiac-related tobacco disease. Okay, so on this slide, this is actually really interesting data that was put together by my colleague, Jody Prochaska, who used to be at UCSF with me and now is at Stanford. And she developed a cardiac version of RX for Change. She also developed a psychiatry version, and I'll walk you through a little bit of the cardiovascular version later in the talk. So standard treatments to reduce the risk of death among patients with cardiovascular disease. Okay, so aspirin, 15%, beta blockers, 23%, ACE inhibitors, 23%, and statins, 29 to 35%. So what we know is that with each puff of a cigarette, blood pressure will increase on average at 20 millimeters of mercury. So think about your blood pressure measures, okay? The blood pressure lowering effects of medications is really modest, and for most single agents, like if you just do one of these independently of the others, about 10 to 15 millimeters of mercury reduction for systolic blood pressure, 6 to 10 for diastolic blood pressure. So smoking will increase the blood pressure in what we call a dose-dependent response, and smoking cessation can lower blood pressure if you quit completely by about 40 millimeters of mercury, which is none of the medications compare. So you can treat the condition with medications, however, it's not going to cure the cause. And so when you quit smoking, you can actually reverse a lot of the negative health effects of tobacco use on the cardiovascular system. It takes some time, but it actually is reversible over time. And so quitting smoking, unlike cancer, where if the cancer process has already started in somebody's body, you can't reverse that by quitting smoking. What you can do by quitting smoking is stop adding on additional risk that you would get if you continued smoking. Okay, so cancer, you can't stop it, but you can keep it from getting much worse if it hasn't already started the cancer process. Now, but with cardiovascular, you can actually reverse a lot of it. So many reasons to quit smoking among patients with cardiac disease. Okay, so let's talk about some of the relations here with post-operative outcomes. We do know that quitting smoking will improve surgical outcomes, but the other benefit, patients that are undergoing surgery, it's kind of a window of opportunity. If you can get them to quit smoking because of the surgery, especially if it's tobacco-related, there's a good chance that they'll be able to quit and stay quit for good, so if you get the right help, okay? So quitting will reduce the incidence of cardiovascular complications. This is all related to surgical outcomes, respiratory complications, wound-related complications, and also preoperative abstinence can decrease the frequency of intraoperative ischemia. And so these are data that have been published in the peer-reviewed literature, and we actually worked with some folks at the Mayo Clinic, David Warner and Lowell Dale, to develop a version of RX for Change for surgical providers. And so that was a really unique version or application of RX for Change that they kind of took the lead on, and working with some of the anesthesiology societies as well as the, I just lost my train of thought, the anesthesiology as well as the wound folks. So smoking cessation reduces postoperative complications. Here are some data from a clinical trial. 120 orthopedic patients randomized to receive a tobacco cessation intervention or a control group 6 to 8 weeks prior to surgery. And if you look at the data here, the control group, okay, the percent of complications versus the intervention, so much lower in patients who actually had the intervention were able to quit. So 80% of intervention patients were able to quit or reduce smoking. And a reduction will lead to an improvement, but it's not as good as quitting completely. Okay, and so here's a citation. I try to leave citations in case somebody wants to pull the original literature. Okay, so we talked about some of the deaths due to secondhand smoke. You know, they're really there's no form of tobacco. They're all harmful, and it's not safe to be around any form of secondhand smoke. So basically, you know, nothing. So secondhand smoke causes premature death and disease in non-smokers and children. It causes SPIDs. It's associated with an increased risk for SPIDs, acute respiratory infections, ear problems, exacerbated asthma. And here's another one, respiratory symptoms and slowed lung growth if parents smoke. And so, you know, when babies are born, their lungs are not fully developed, and so if they're exposed to that, it slows the growth of those lungs. And then in adults, we've already talked about this, but most, you know, a lot of people are still exposed to smoke in their homes and workplaces. I know you've all been driving down the road and seen, you know, a mother or a father smoking in a car with small children in the back, and it just, you know, just breaks your heart because there's no way that they can get away from that. Indoor spaces, eliminating smoking fully protects non-smokers, but, you know, having a separate area, ventilation, cleaning, none of those are effective. There are still harmful levels of smoke that individuals can be exposed to. And, you know, there have been several studies recently, meaning in the past 10 years, that have shown that indoor smoking bans have led to reduction in the number of acute myocardial infarction admissions to hospitals. And so, for example, in Helena, Montana, there was a study. This is the first one that was done that was actually, it's my favorite study ever published, to be honest, that I've ever read. Or what they did was they had no smoking ban, then they implemented a smoking ban in the area of Helena, nothing outside of it, just that area, and then that was reversed. And so what they had was they showed a 40% reduction in the number of acute myocardial infarctions admissions to the hospital during that period when there was a ban. And then when they reversed the ban, the legislation was reversed, that went right back to where it was. Okay, and so that tells you that, yeah, it's probably related to the ban, but the other data that was really of great interest to this and provided some more credibility to the validity of that is that in all of the areas surrounding Helena where no ban was ever implemented, their level of admission for acute MI stayed the same throughout the study period. So that was the data that then pushed the CDC to move forward with some of their recommendations for the indoor smoking bans, and it's really, to me, was pivotal, absolutely pivotal in a lot of the indoor legislation that's been passed over the last couple of years. So, okay, so let's talk a little bit about smokeless tobacco. I did say there's no safe form of tobacco, but we do know that use of smokeless tobacco will have a lower incidence, is associated with a lower incidence of lung cancer, for example, for obvious reasons, because smokeless tobacco is absorbed through the mouth, right? It's not going into the lungs, it's not smoke. However, you have an increased risk of oral cancers and pharyngeal cancer, and so oral leukoplakia, which is a precancerous lesion in the mouth, is what you see here. So it also causes dental caries and gingival recession, bone attachment loss, and so forth. So it's very bad for your mouth, basically. Nothing good about it. Okay. And so in the United States, and these data were just updated in the Surgeon General's report, and this number here I find to be astounding. For every pack of cigarettes smoked, it costs society over $19 in costs. So that includes healthcare expenditures, lost productivity due to premature mortality. That doesn't include lost productivity because of increased morbidity. That's just mortality. So these numbers are conservative. The total economic burden is almost $300 billion per year because of tobacco, very high. And so, the states that are, going under because of healthcare costs, they really need to look to the cause of that and ramp up their smoking cessation programs. There really is no more effective intervention in terms of reducing healthcare costs and smoking cessation. So it should be on the top of everyone's radar. Okay. So we talked about some of the, health consequences of smoking. What about the health benefits? What are they? So, really within 24 hours, you start having some effect on blood pressure and other things. But the main things to mention here, you've got increased lung function. These are pretty short timeline, 2 weeks to 3 months to get some of these improved circulation, walking becomes easier. On the right, in 1 to 9 months, you've got really improved effects on the lungs, noticeable improvements. Now, some patients will say, sorry, I have a bird who's having a good time back there. Sometimes patients will say, well, it made my lungs worse. Well, the truth is when you quit smoking, it does feel worse for a while because your lungs are starting to clear the mucus. They're trying to get the crud out. And so it does get worse for a short period of time. After 1 year, excess risk of coronary heart disease decreases to half that of a continuing smoker. Okay, so this is some of the benefits that I said gets reversed over time. Risk of stroke is reduced to that of people who have never smoked after 5 years. And then lung cancer death rate drops to half that of a continuing smoker. And again, that's really not technically a decrease. It's because you don't have additional risk adding on. And so after, it's technically 10 to 15 years, risk of coronary heart disease is similar to that of people who have never smoked. Okay, so lots of benefits of quitting. And we do know that on average, cigarette smokers die approximately 10 years younger than non-smokers. Okay, so it's not just about the length of life, it's about the quality of life as well. And that's the, kind of one of the main messages that we give to patients. Yeah, there's always a patient who says, so what if I die a few years early because of smoking? Well, it's not just about that. It's about how you live your life and how you feel and how you go through your life. And so of those who continue smoking, at least half will die due to a tobacco-related disease. Okay, now these data come from British physicians, male British physicians, one of the longest, best studies ever done on tobacco by Sir Richard Dahl, who was like the tobacco cancer epidemiologist from England. Wonderful guy. But what we know, even though these are male, we know that if women smoke like men, they're going to die like men. And so the data show very clearly that it's not just about men. So even though that study was about men. So let's talk a little bit about nicotine pharmacology. So what happens when you smoke a cigarette? Within 10 to 20 seconds, the nicotine reaches the brain. That is faster than D-glucose, which is the primary energy source for the brain, very rapidly, okay? And so what happens then is, you get that rapid satisfaction. It's actually alleviation of withdrawal in most, and so that keeps you coming back for more. So that immediate reinforcement, from the nicotine replacing, going or alleviating withdrawal. So nicotine pharmacodynamics. So pharmacodynamics is what the drug does to the body, as opposed to pharmacokinetics, which is what the body does to the drug. It breaks it down, it excretes it, and so forth. So talking about pharmacodynamics, what are the effects of nicotine? Well, you can see them here, and this is no mystery to anyone. You've seen it. But these are all the positive things about tobacco, which make people want to continue smoking, okay, on the left. And then on the right, we talked about the increased heart rate, cardiac output, increased blood pressure. Nicotine leads to coronary vasoconstriction as well. And so these are the things that are going on in the background. So we have to try to counteract our interventions for cessation with trying to deal with the fact that patients want to continue to smoke for all the positive reasons. They enjoy it. It feels good. It keeps them out of withdrawal. So, but we have to think about tobacco use as well as cessation as kind of a pyramid, thinking about the individual, the pharmacology, which we just talked about, and also the environment. People that are around them, we've got tobacco advertising. Some people associate smoking with very specific behaviors, like they have a drink and they smoke a cigarette. Okay, and they also with certain people, social interactions as well, okay? So when we think about tobacco dependence as well as cessation, we think of it as a two-part problem. The physiological, where you're addicted to nicotine, we have treatments, FDA-approved, proven medications for cessation. We'll talk about those. But it's also behavior. Some people call it a habit. To me it's an addiction, and you keep going back for more. So, but we have treatments for that. It's a behavior change program, and sometimes we like to separate those by treating the behavior first while we give them a medication that replaces the nicotine, so they can work on the behavior and then later taper off of the nicotine replacement therapy, and that which then addresses the physiological. But both of them are important, and it's true that a medication on its own can improve patients' ability to quit. However, it's better if they get the behavioral counseling with it. And you really want to stack a patient's deck. You want them to have the best chances of quitting by giving them the best help that they're willing to take. Okay, so first let's talk a little bit about the behavior. I mentioned the clinical practice guideline was released in May 2008, which is unbelievably a long time ago already, and this is the third version. So a lot of organizations worked on this together. It's a series of meta-analyses that basically states recommendations for how to proceed with cessation interventions. So we did mention the effects of clinicians improves the patient's ability to quit, and here with the reference group of no clinician, non-physician clinicians will give them a 70% increase in their ability to quit, and physician clinician more than doubles patients' abilities to quit, okay? But I would say, these are averages. It could be any one individual that resonates with any one patient, that makes that difference for that patient and pushes them forward to help them quit. So, everybody being involved is important, even if you're not in the 2.2 bar with the physicians. And then at the very beginning of this talk, I also mentioned that the more types of clinicians that help a patient, the more likely they are to be successful. And these are pretty significant numbers here. However, even at the best bar, which is 2.5, if you look to the left axis here, the y-axis, what you'll see is it's really just under 25% of patients are able to quit and stay quit at 5 or more months. We have a lot of room for improvement. And so, we continue to work on this, but, quitting doesn't happen overnight. And that's what you have to tell patients. It's, it's like learning anything else. You're learning to be a non-smoker. Okay, so in the clinical practice guideline, they delineate a 5-stage process for helping patients quit. And I love this framework. It's simple. Clinicians get it. It doesn't use a lot of theoretical jargon. So, you ask about tobacco use. You advise patients to quit. You assess readiness. If they're not ready to quit, you give them a very different intervention than if they are ready, right? You assist them with quitting, and you arrange follow-up, and that's where home health care comes into play in a very significant way. So, we talk about arranging, and unfortunately, this is the piece of the 5 A's that rarely gets done. There's an intervention, and there's no follow-up at all. So, huge opportunity here. If we could operationalize a way to make this transition happen, that would be fantastic. So, you can see here, it's essentially linear. The number of sessions, it doesn't matter how long they are sometimes. More is better, but the number of interactions with the patient, it actually has a significant increase in their likelihood of quitting. So if you get multiple clinicians, multiple sessions, medications, and the behavioral counseling, then you're going to pretty much maximize their chance of quitting. And it doesn't mean that this has to be one person or one office or one home health care group doing all of this. Part of this can be done through referral to quit lines or through online programs, or there's all kind of options now for cessation. So we'll talk a little bit more about those in a minute. But it's key to essentially to assist the patients throughout the quit attempt, you know, and to make them feel like they can come back, but also not feel like if they slip up, if they relapse, that they're being judged, okay, because it's a very sensitized topic for patients. Most patients who smoke are not proud of it, and so they don't want to be lectured. They want an advisor who's part of the plan, who's not directing the plan for quitting, okay? And so I mentioned about referral. You know, I always tell people that I train, if you don't have the time or you don't have the expertise, anybody can ask about tobacco use, advise patients to quit, and refer them to other resources. And sometimes just that little intervention can be all the difference, okay? And so here we talk about is having someone else do assist and arrange, and that could be the quit line, 1-800-QUIT-NOW. Here's a number. You know, so the Ask Advisor for intervention could be done in less than a minute, to be honest, you know, and if we all did that with every patient, that would be amazing. So brief interventions have been shown to be effective. Interventions is, you know, less than 3 minutes have been effective, okay? So here's the number, 1-800-QUIT-NOW, and you know, you can get cards from the tobacco quit line in your state. They would probably be more than happy to provide you with whatever materials you would need to help push patients to the quit line. You know, and I actually, I had a research study where we had pharmacies ask, advise, and refer to the tobacco quit line, and let me tell you, they soaked that up, and we had a significant increase in the number of patients who referred. I mean, huge increase, and just with even a small number of pharmacies, we had 64 pharmacies in our study. So really, you know, and clinicians want to do something, but they don't always have time to do it all, so they want to find a brief way to make a meaningful contribution. But if you can do the follow-up with the quit line, you can actually have the quit line call the patient if they want that. So that's called a proactive referral versus a passive referral where you just give the patient a card and say, call them. You know, they'll help you. And I've sat beside the counselors at Free and Clear or Lear Wellbeing, which is based in Seattle, and they service 20-some states now. Those counselors are amazing. And that's me saying it, who's been counseling patients for, like, you know, God knows when, 20-some years. So I think they do a terrific job, and it's something we should all be doing more, promoting the quit lines or group programs. Have also been shown to be effective in the clinical practice guideline and recommends it. They don't recommend online programs, but that's only because there was enough data at the time that the guideline was published. But, you know, my theory is, you know, we've got all these options. Find what works for every patient and direct them in that way. You know, even if hypnotherapy doesn't work on the average for patients, doesn't mean it won't work for some. It worked for my best friend. Would I have recommended it? No, but she quit, and she's been quit for 15 years. So, okay, so let's talk about the physiological. Behavioral is essential. You know, pharmacotherapy, well, the clinical practice guideline tells us that all patients attempting to quit should use effective medications for tobacco dependence treatment, except where contraindicated or for specific populations where not so much that it's not safe, but there's insufficient evidence of effectiveness, and that's pregnant women, smokeless tobacco users, individuals smoking less than 10 cigarettes a day, and adolescents, okay? So those are the groups that there's insufficient evidence. Doesn't mean that it can't be used, but, you know, with appropriate precautions. So I'm going to talk briefly about the medication options. I do want to leave time for questions, so we're going to get through this. We have 5 nicotine replacement therapy formulations. The very first one was a nicotine gum, and I was a pharmacy student at Ohio Northern working in Lima, Ohio, the group that just got the applause, and when Nicorette came on the market, I thought, God, what a great idea. And then after that, it was the patch came out, and then the lozenge, and now those 3 are available without a prescription. And now, but they weren't back then, there were prescriptions. But now we have nicotine nasal spray and also the nicotine oral inhaler, which are on prescription. And the transdermal nicotine patch, although you can get it over the counter as Nicoderm CQ, there is a prescription formulation that can be dispensed with a prescription and therefore perhaps covered by insurance. So those are the 5 different NRT options, and what I really like about these options is that you're not introducing a new chemical agent like you would be with the tablets that we'll talk about in a minute. However, all of them are essentially equally effective. They're all effective. And so what we see here, though, and the problem with the nicotine replacement therapy is a cigarette is very rapidly increase the plasma nicotine after you smoke, and we talked about this a few moments ago. And also moist snuff is not as rapid, but it gets very high. Now, these are the ones that you can buy at the front of a pharmacy, which is kind of the bane of my professional pharmacy existence. I've been working on that, and CVS is now tobacco-free, yay. But all the nicotine replacement therapy products are these lines at the bottom, so they don't get as high and they don't work as quickly. And so what does that mean to the patient? Well, their satisfaction's not being immediately relieved. And so part of the counseling message for patients is that it's not going to act like a cigarette. You need to keep it on board in your system to prevent cravings, to prevent withdrawal, not to treat withdrawal. And that is something that seems to get lost in almost every counseling interaction. Patients wait till they need it, then they take it. Well, that doesn't work. You know, it's not going to work for you that way. You know, the beginning dose for these, some of these, like the nasal spray, the inhaler, the lozenge, and the gum is a minimum of 9 doses a day when they start. 1 dose every 1 to 2 hours. And if that's not something a patient can do and adhere to, then it's not a good option. Use the patch or use one of the tablets. So lots can be told to patients about the medications. You know, even just to get them to read the box would be a good start. Okay, so especially for the gum, they think, you know, it's just gum, just chew gum. Well, there's a very specific way to chew it because nicotine's being released. It's not just chew it. It's a chew park based on whether they feel a tingling, which is the nicotine being released from that piece of gum. So I could talk for a long time about the medications, but I won't. So the other options here are bupropion and varenicline. And so bupropion is available as Zyban and a generic, and varenicline is only sold as Chantix. There is no generic. It's, you know, hasn't gone through the time course to get a generic yet. But these are also very effective medications. And the nice thing about this is it's oral dosing, okay? And so where the other ones are not. Well, the lozenge and the gum are, but it's a different type of dose. So here what we see is a graph that demonstrates the long-term, which is defined as 6 or more months, quit rates for available cessation medications. And these are all of the FDA-approved medications you can see here. And I don't want you to look at just the yellow bars because these were active drug versus placebo. That's it. So, you know, the population for varenicline looks to be the most effective. And it probably is, to be honest, but these are not head-to-head trials, so you really can't compare it that way. Populations could be different. There could be a lot of other confounding factors. But, you know, if you look across the blue bars, you know, they're pretty similar, the control groups, to the placebo group. So, you know, varenicline looks to be the most effective. However, you can't really say that. I mean, look at the nicotine nasal spray. The problem with that one is people don't want to stay on it because it burns. And who wants to use a nasal spray? It's actually not a very popular product, except perhaps among mental health providers like to use that product. It has a more rapid onset of action compared to all the others. So they're all effective, and we should be using them. We should be recommending them. And now in the clinical practice guideline, you know, they recommend combination therapy. So you could have a patch on, a nicotine patch, and then use a lozenge or a piece of gum when you have situational cravings where you think you're going to want a cigarette. And you're still going to be fine with your nicotine levels. You saw the graph. You've got a lot of room to go up to get where you would be with cigarettes. So, and some patients say, I don't have the money for it. Well, in reality, it's cheaper for most patients to use the medication than it is to smoke. And so, you know, if the average pack of cigarettes is $6.18, which is the current figure for the United States, and highly variable by state, but you know, most of these are less than that per day, assuming that you smoke a pack of cigarettes a day, which is 20 cigarettes. So these two are a little higher, varenicline and the inhaler, but it's for short-term use. You know, it's for 3 months, and then you're done. So where if you smoke, you're going to be paying that for the rest of your life. So huge difference. All right, so I do want to talk a little bit about some of the opportunities in home health care, but first of all, to say, to maximize success for any patient to quit smoking, interventions, I'm shouldn't right, should, they must include comprehensive counseling and 1 or more medications with follow-up care, okay? You're going to increase your chances of quitting if there's no follow-up care, but if you do follow up, chances are much more likely, okay? Home health care provides a truly unique opportunity to capitalize on these windows of opportunity. Patients are being transitioned from different settings with follow-up care, with frequent contact, you know, even minimal interventions. Just talking about how are you doing, what have your challenges been in the home setting could be huge in terms of helping patients stay on track, helping to assess what their challenges will be at home before they even go home. You know, for example, modification, we see down here, modifications of home environments. What needs to be done to make sure that you can stay smoke-free once you leave the hospital? Who in your home is a deterrent to that? You know, and maybe establishing some rules for people smoking outside, getting rid of ashtrays, changing routines where you normally would smoke. I could spend hours and hours talking about this because there's so many opportunities. And it's interesting because I've never smoked in my life, but you know, having counseled so many patients over the years, you hear what works for all these individuals. And so, and everybody's different. You know, for example, one of the excuses you know, for not using a medication that patients often say is, well, I don't have the money for that. It's $50 for a box of gum. Well, one of my students actually said, well, why don't they ask their friends and their family members each to donate $5 toward that first box? And so that would be paid for. And then the money that they would save from not smoking will go into a can, and then they will pay their friends and their family members back. What a great idea. No patient ever came up with that, but you know, I use that all the time now in my lectures and in working with patients. So I think some opportunities really exist for this group for follow-up care for especially, you know, tobacco-related diseases, but not just for that, but for people who are going to be in an environment where smoke, you know, in a smoking environment, whether they smoke or not. Establish formal handoff protocols for cessation assistance. So what happens? I mean, how do you handle that? I'm sure everybody's different across the country, but when a patient transitions from one setting to the home setting, what is done in terms of transition related to tobacco cessation interventions? Is there even one? I don't know. I think in some places there are, and others there aren't, and sometimes, you know, somewhere in the middle for most. So try to establish that, formalize it, make cessation follow-up a part of the transition, the handoff protocol. You know, and it can be a formal continuation of inpatient cessation programs. You can refer to the quit line or other resources, whatever works for the patient, but at least start the discussion. You know, so here in your chart, it shows that you were you were using the nicotine patch while you were in the hospital. Let's talk about what our plans are for when we get home. And so, lots of opportunities here. And it's quite shocking to me that this has not been a focus really ever, in my knowledge, in the tobacco literature for home health care. So I encourage you all to work together on this. And then the other thing is, you know, it's really an opportunity to enhance response to treatment. So even if you think of cancer, you know, cancer is bad enough in itself, and almost all cancers are associated with tobacco use. Doesn't mean they're all caused by it, but most of them are. But the truth is surgery, radiation, and chemotherapy, all three of them are negatively impacted by tobacco use. And so what does that mean? So our cancer care doctors should be addressing this with patients, and maybe some of them are. I know they do at MD Anderson, but you know, some people say, oh, they've already got cancer. Why make it harder on them? Well, you know what? If you're going through this crappy treatment that's going to make you feel awful, and why wouldn't you want to maximize your chances, right? So lots of opportunities related to that, and, you know, wound healing, and, you know, you saw the data. It really does makes a huge difference in complications post-operatively. And so big opportunity here. Okay, I'll get off my little soapbox there. Okay, so I was asked to present a little bit of information about some resources that we have, and this is the RX for Change program. It is based at UCSF. This is the website. You can see here we have different versions, and these can be used to train healthcare providers. We've got the 5 A's, the Ask, Advise, Refer for brief counseling, a psychiatry version, cancer care providers, which I developed, cardiology providers, which is Jody Prochaska. That's what I'm going to show you here in a minute. Mental health peer counselors, and surgical providers. And so different versions, they're really all about the same. The only difference is that we focus a little more on the specific disease state. So, and we also have Spanish language. In fact, these folks that we're working with now have done some Spanish translations that they shared, which is just wonderful. And this is like one big happy family with RX for Change, a lot of people working together all over the world and in all different disciplines. And so it really making a difference, I think, in tobacco education worldwide. So on our web page on the left, just some basic information here, the visitor navigation menu. Here's the available versions. You can register on the website. It doesn't cost anything. We share everything. We don't care what it is. You can have it for free. We want you to use it. And so do have to register, and you do have to agree to an end-user license, which basically says you're not going to use this for profit. You cannot sell it. You can't go on the speaker circuit and be making a living off of it. But it's a very generous license, and it's really we only have it because we borrowed materials from other people and put it in our program, and we promised that we would have that condition that other people wouldn't use their materials for profit. So so this is where you would log in at the top right, and basically, you know, I'm a hockey fan, what can I say? I'm a Penguins fan, and I always sign in as Sidney Crosby. Little does he know. But you would log in here, but you do have to register, like I said. And once you get in, you get the content navigation menu. These are the different versions on the left. I guess I'm probably flipping through pretty quickly, but I do want to leave time for questions. You can click on any of them. You can click on the left, or you can click over here, and this is a brief description of them to access the materials. And then once you get in, so for example, in the 5As, we have teaching materials, we have case scenarios for counseling. And this is more, part of this, like the case scenarios, is really useful if you have more of a workshop. You know, I use these in class. We have a lot of video segments that demonstrate appropriate counseling, some recommended readings and so forth. We also have some CE programs that we don't provide the CE units for, but they're prepackaged. So if somebody wants to use that, they can. But you can really take our materials if you want to do whatever you want with them. You can pretty much shorten your talk, whatever. So if you click on teaching materials, then what you find here, you know, the PowerPoint slides. These are the different modules of RX for Change. Introduction, Epidemiology of Tobacco Use, Nicotine Pharmacology, Principles of Addiction, Drug Interactions with Smoking, which is actually really important and nobody knows about it. It's not nicotine interactions, it's actually the smoking. It's the combustion products that have some clinically significant interactions with medications, especially for medications used to treat patients with mental illness. And then assisting patients with quitting, we do up to 2 hours on that because it's so important. And then aids for cessation. And this is the full module, the core modules, which you could take 6 hours. You know, we recommend 6 hours, including counseling and so forth. But, you know, when you're a clinician already, you know, people do much shorter. You do what you can. You know, then we've got some optional modules here. Yeah, if you scroll down. And then we've got these handouts, which were just translated into Spanish for us. And so these are very useful to guide counseling, tobacco cessation counseling guide sheet, withdrawal symptoms information sheet, which is really good to hand out to patients. These are things you could expect, and this is what you can do to alleviate them when you quit smoking. And then we have this very important drug interaction with tobacco smoke tool that delineates every drug interaction that's known, how it happens, and the extent to which it modifies the level of that drug, okay, the concentration of that drug. Different tools, tobacco use log, coping strategies, planning for change worksheet. This actually, our curriculum was used by GlaxoSmithKline for more than a decade. You know, none of the authors of the program have ever taken a penny from pharmaceutical industry, but we share, and anybody can use it. And that's one thing they liked about our program is it wasn't funded; it was unbiased. So they actually wanted us to develop something like this for use in doctors' offices, planning for change worksheet, and we did that. It was a really good idea. It was a good addition. The other really important tool that we have is the pharmacologic product guide, the third one from the bottom, which summarizes all the medications, all the dosing, everything about it. Very, very useful. That's probably the most heavily utilized piece of curriculum content that, that we have for folks. Now, under the video segments section, I mentioned you know, lots of videos that you can use to demonstrate appropriate counseling sessions, and these were all professionally done. These are professional actors. We had a producer, you know, so very good for different settings, you know, different stages of readiness to quit, different types of healthcare providers, and so forth. So lots of options. And we also have what we call trigger tapes. So, for example, this guy here on the very bottom left, trigger tape 3, says, no, I think I'd rather quit cold turkey and do it on my own. I don't need no help. Well, how do you respond to that? These are challenging things that patients say that, like, you go, oh, okay, well, what do I, you know? So we use that to teach, and this is an approach, a trigger tape, which is an approach that's actually won awards, teaching awards. And so we've integrated this into our curriculum to make it more interactive for the audiences. And I don't know about healthcare providers, but because I don't do formal assessments like I usually do with students, but they love it. They love all the videos. And 40 trigger tapes, and you can just scroll through and watch them. And then we have the CE programs, as I mentioned, but, you know, this is just us putting things together to make it easier for other people. So it's all just a subset of the larger slide set. Okay, So I did want to stop, and I promised I'd give 10 minutes, and I've given 11. So any questions, I'm happy to answer. And if there's any follow-up, if anybody has any ideas for how to integrate tobacco cessation into the home health care environment, I would love to hear it and work with you. And I'm not sure
So for those of you on the line today, yes, for those of you that are on the phone lines today, we will be unmuting the lines, so do take that as a warning so that you will mute your own lines if you don't have a question. We don't want to eavesdrop on your calls or your conversations. And for those of you that do not have the phone line and you are using your computer, if you open your chat window and send your questions, you can send them directly to us or to all participants, and we'll make sure we get them answered. So, Misty, are the lines open?
Give me just 1 second.
Sure.
Okay, everybody's now unmuted.
All right, we'll start with the phone lines. Does anyone have a question on the line today? If you do, you can jump on in. I'll just take a moment here and say, for those of you I don't know, I'm a family nurse practitioner, and I've been that for a while, and I felt I was pretty well versed in tobacco cessation, but I've got to tell you, Karen, you brought out quite a few good points that I had. Some I had forgotten, but some I did not know, and thank you for bringing forward the studies as well, because that's fantastic. I think the first thing I think we all need to remember, especially in home health, is that every puff of smoke, where you said it brings up the blood pressure 20 millimeters just with smoking the cigarette. So as we're in the home taking the blood pressures, it's something to consider. If your patient is actively smoking when you're taking the blood pressure, which many are, as they're actively smoking, the pressure is going to be an altered reading. So as we're moving forward with the preventative cardiovascular care in the home, blood pressure readings are critical, really. And that's a very good point to bring forward. I thank you for that.
Yes, it is important, and also an opportunity. So even just asking patients, have you given any thought? What are your thoughts about quitting? Not in a way that is, judgmental or feels threatening. You don't want your patient to become defensive. But one of the things that I like to ask folks is, do you ever plan to quit? And if they say yes, then my follow-up question is always, so what's impeding you from quitting now instead of later? And the truth is, it's not going to get easier to quit later than now. So why not quit now and incur all those, health benefits sooner? And most patients, that actually resonates with patients a lot. A very brief intervention sometimes can just be enough to push someone forward. And it doesn't have to be, they don't have to feel judged. It's just really asking a question. What are your thoughts about that? May I tell you what concerns me? We talk a lot about motivational interviewing, and I don't know if this is the language, it's an approach, it's a way to talk with a patient, not so much talk to a patient. And we tend to be very directive in, every healthcare provider in talking with patients, but we really need to be more of an advocate for everything, but especially for something like this. And really, how can I, what are your thoughts about quitting, and how can I be helpful? It's their decision, and I'm here to help, as opposed to I'm here to tell you what to do. Just a different approach.
Fully agree. And just for those of you on the line, motivational interviewing is covered in the self-management best practice intervention package on the HHQI website, because this is something that, as you said, it is not just jargon that is the medical jargon being thrown around of the day. It's actually a technique that the evidence truly supports it. That, as well as teach-back, they join together for, as you said, not talking down, but engaging the patient in how to be most effective as a clinician. They're actually going to tell us. We do have a few questions, and I'll start with the first one. It's asking that in working with patients at home, often pets play a big part. Are there any studies done on pets and secondhand smoke?
In terms of pets being harmed by secondhand smoke? Yes, there is. Although I'm not up to date on that literature. That's actually an older literature, and it is definitely, can definitely impact them. In fact, I have a friend who always tells a story when he does a training that he tried to get a woman to quit smoking for many, many years, actually. And she finally came in and she said, I have to quit now. He said, well, why? What's going on? He said, it's Fifi. So her dog, it's true. That was the reason she quit smoking. You know, and that's what's really important about talking not to a patient, but with the patient, is understanding what is important to them and trying to parlay that into reasons to quit. And so that's, you know, an important approach in our counseling. And so, yes, absolutely, it can be harmful to pets. It is harmful. And I once went into a pet store, I kid you not, and there were birds who were so vulnerable. And this was in Pittsburgh, in the south side of Pittsburgh. I'm from Pittsburgh. And I walked in because I love birds. As you know, I have a bird who was tweeting throughout the talk. But and the woman was smoking in there, in the store, in the pet store. And I was just shocked. I said, oh, my God, this poor little bird was like 4 feet from you. Yeah, it was awful. But, yeah, it's harmful.
Well, personally, I think you showed great restraint from
I did.
not saying
my friend was
I
very proud. He was the one that had the Fifi. He's my tobacco colleague that I do everything with, Frank Vitale. He's the greatest trainer on the planet for tobacco. Yeah. Okay, next question.
Well, that's a really good question. Thanks for that. And another question that we have is, how do you talk with a spouse about smoking in bed and falling asleep when the individual denies that it's even a dangerous problem?
How do you talk with a patient when they're in bed smoking and they deny it? Is that the question?
Yeah, it sounds like it's a spouse of a patient who is smoking in bed and falling asleep with a lit cigarette and even denies that this is a problem or a dangerous problem.
That's a good question. I've never had that problem. I've never had that encounter myself. How would I handle that? I would say, may I tell you what concerns me? I would first try to enter the conversation in a way that she did not feel threatened or he did not feel threatened.
Mm-hmm.
And so, you know, people do get defensive about their smoking behavior, as you know, but if you come at it with a different approach that says, you know, I have some very genuine concerns, may I tell you what they are much more likely to be receptive than if you just tell them. So that would be my first thing, is to enter the conversation in a way that shows autonomy, not me telling you what to do, because people don't want to be pointed out and they don't want to say you need to do. So, and then I would say, here's my concern. I worry that you could potentially fall asleep or, you know, whatever, then tell them what concerns you. And I think you will find that with this approach, patients will be more likely to listen. Now, will it create change? It depends on the person. It's a really hard question to answer without actually knowing the situation who you're dealing with. But I always try to go gentle with patients like that or spouses like that. So I'm not sure that's the best answer, but that's how I would approach it. You know, but then again, there are patients who need to hear it in a firm way. And I always give the example of my mother-in-law who smoked for 50 years, and she wouldn't listen to my husband who's never smoked a puff of a cigarette. She wouldn't listen to me, anybody. But when her doctor said to her endocrinologist, she had developed diabetes, she said, if you don't quit smoking, I will no longer be your doctor. If you don't care about yourself, then why should I? That was what got her to quit smoking. So everybody's different. It really just depends on the situation. You know, that's not an approach that I would ever use, but you know what? Maybe on some patients it would be the right one. So it just depends.
And that's what we're finding with, as you mentioned in this, the transition from a patient moving from the hospital into home health or from the physician's care into home health. The smoking or the tobacco use transition information is sometimes not relayed. It's not a high priority, or so it seems. And bringing it into the home health clinicians, these are nurses and therapists who have worked with the patient. They're in their homes. They know their birds, their dogs, their animals, their spouses. And this might be the place that the patient will actually hear this information for the first time, even though it's been given to them in all different techniques. And thanks for the information on the motivational technique, because I think that information for all clinicians is transferable not only with tobacco use, but also with all types of teaching that we work with.
Yeah, motivational interviewing is actually, I would say it's a recommended strategy in the clinical practice guideline. And there's been quite a bit of work with case managers in motivational interviewing by Bruce Berger, who used to be at Auburn University. And so there's a lot of good training programs for that. If one has not had that, I highly recommend it. It changed the way I talk to patients completely.
Oh, that's a really great resource, and we thank you for that, and as well as everything on today's call. We are coming up at the top of the hour, so before we close, I will just mention to all of the participants today, thank you for taking your time to join us. The next Cardio Land call will be 1 month from today. As you see, it's March 19th from 2 to 3 p.m. Eastern. Do remember that if you are not a Cardio Land member, you will not receive the invitation. This is targeted. It's not meant to be selective, but you do need to be a member in order to receive the webinar invitation. If you have any questions about that, please contact us at HHQI, and we'll be glad to help you with it. The content on next month's call will be covering women's cardiovascular health, looking at the disparity in care, looking between women and men as far as symptoms and as well as treatment. Now, the invitations, as I mentioned, they will be sent out the day before, just like this one was, so don't panic if you don't receive it until the day before. Do make sure you do check your trash or your spam file, because sometimes they do go in there accidentally. And if you do not receive it, just call us and let us know. Want to give out a special shout out to let you, or remind you actually, that the HHQI University is now open for class, and some of the classes that will be coming up do include tobacco effects and smoking cessation, as well as blood pressure control. So if you have not participated in this free continuing education for registered nurses, please feel free to do so at any time. It is now open, and this is accredited at a national level, so the CEUs are yours. They're free. All you have to do is log in and take them. And there's multiple classes in there, very short time periods, so that you can do it, because we do understand that in the home you are completely busy. So with that, we will say thank you to everybody, especially Dr. Hedman, for taking the time to present this information to us. We appreciate it, and we hope that everyone has a great day. Goodbye.